Uh, Welcome back, everybody. Today, I have the pleasure of being joined by Dr. Elysse Prussing. She's a midwifery academic at the University of Newcastle, and we're going to be talking about modern day birthing and some of the challenges that we face there. So, Elysse, thank you very much for joining me today. It's an absolute pleasure, and I can't wait to learn from you.
Thanks, Mo. Thanks for the invite. I'm looking forward to our conversation, actually. The questions look great.
Uh, Thank you. It's, hopefully that some of the information that you'll provide will be of benefit to people watching this episode. I'm sure that it will be. Um, so, Elise, can you give us a little bit of your background? So, you've done a lot of research. You obviously work as a midwife as well. And yeah, maybe just sort of explain to us what got you into midwifery and what your interests are that led to your research.
Sure. I guess I'll probably start at the very beginning. My journey into midwifery started with the birth of my eldest daughter, Leela. Um, I can remember really distinctly sitting on the postnatal ward and learning how to breastfeed my beautiful brand new baby. And this lovely young midwife walked over because I'd pressed the buzzer and just wanted to check that I was doing everything correctly. Because, when you're a brand new parent, everything's new and you're nervous, just want to do absolutely everything correctly. And she just made me feel so special that I was doing everything right. And she gave me a few little tips just to correct her position. And then I've never forgotten the way that she made me feel. And I just thought, oh my God, I would love to be just like her and make women feel just as special as she made me feel. And it was such a small tiny little thing that she did for me, but I just couldn't believe how proud of myself I was and how special that she made me feel. So that's where my journey into midwifery started. I literally signed up to, Leela was born in October, and I had signed up for a Bachelor Midwifery program 2 weeks after she was born. And I think she was about 3 or 4 months old when I started. So it was a huge life changing moment for me having her. Brett and I moved all the way back home from the Gold Coast to Port Macquarie, and it was the first year that the University of Newcastle had offered the Bachelor of Midwifery at the Port Macquarie campus. So, yeah, that's where my journey into midwifery started. As an undergraduate, I quickly learnt the value of what's called midwifery continuity of care. So, having the same midwife throughout pregnancy. They're on call for birth, and then in the postnatal period, you provide care to the woman as well. At that time, Port Macquarie wasn't offering midwifery continuity of care as an option. It was the standard fragmented medical led model where you could see a different midwife at any appointment. You met a new person at birthing, and then you had multiple midwives on the postnatal ward. Within like one day, you can have up to 3 different midwives looking after you. And that's pretty standard across Australia in a hospital setting. But as part of our undergraduate program, we had to follow 30 women as part of our requirements. So we followed continuity of care women throughout the 3 years of our program, and that meant that we went to their appointments with them. They called us when they were in labour, and we met them at the hospital and helped look after them during labour and birth, and then we looked after them in the postnatal period as well. And I feel like they were some really formative experiences for me and have really influenced my career and my passion for continuity of care. And that's, I think, those relationships with those women, I've never forgotten, some of those experiences. And they're some of the highlights that I've really cherished since my undergraduate studies. And that's, I I really wanted women to have that kind of care. There's a lot of evidence behind midwifery continuity of care, and the improved outcomes, like reducing interventions like cesarean section, instrumental births. There's lots of great outcomes for the babies as well. So some evidence shows that it can reduce preterm birth, stillbirth, neonatal loss, admission to special care nurseries. So they're really quite significant, important outcomes that continuity of care can contribute to. And I just have always wanted all women to have access to that standard of care. I feel like that's something I just couldn't believe that we had all that evidence and that we weren't implementing those models and women didn't have access to it. So I was really passionate about that. And I really love how research can influence our everyday practice in those clinical settings. So I pursued in my graduate year an honours degree, and then that led into me pursuing a PhD. So poor Brett had to put up with me studying for a very long time.
Good supportive
um,
husband.
Yes, yeah, he didn't say no, but he had to put up with, the washing being washed and sitting in the clean clothes basket and not getting folded and put away for a few years. But that was the compromise, I guess. I've been able to do something that I'm really passionate about and I love and really truly believe in. And yeah, I have been really well supported, and my family have been very understanding.
No, that's good, and I think again, just from a male perspective, it's good to support, your wife or your partner as they are taking on study and things that they're passionate about. Especially as you said that this has had your first experience with that midwife had such a touching effect on yourself. Um, no, kudos to Brett, and shout out to all the partners that are supporting their partners through
Yeah,
this.
absolutely.
Uh, Elysse, you mentioned about the evidence that shows that continued care can reduce interventions in
Yeah.
patients. Why is that? Is it because that the mother feels more comfort, there's less stress involved? What's the mechanism at work there?
Yeah, that's a good question. We don't really understand what it is that contributes directly to that happening. But from all of the, time I've spent learning and looking at this as a topic, I really believe it is that trust that you develop with that regular, familiar face. And a lot of women do talk about this, that it's so different to fragmented care where you meet someone new and it's such a limited time where you have that opportunity to build a rapport with that person. They don't often share things with a new care provider because they don't feel comfortable. They don't have that history of, developing, oh, this person's okay, and they're not going to judge me, and I don't have to repeat, like, for example, a lot of women talk about they might have had a previous birth experience, pregnancy experience that was traumatic for them. And then they have to reshare that experience with the new person every time they meet them for an antenatal appointment so that person can understand where they're coming from. And quite often they will end up not sharing that information and it gets overlooked because, I'm sure you've been in an experience where you've been in an antenatal appointment and the clinic's behind. So they're trying to rush everyone through to catch up and see everyone and do the bare minimum. And that happens often because it is a busy environment and the doctors get called away for things, or the midwives might have to go and support someone in birthing or on the postnatal ward if there's an emergency happening. So there's there's a lot that goes into that, but I definitely feel that the link between reducing interventions and picking up things early that could possibly end up being an adverse outcome and preventing that from happening, that we see those outcomes in continuity of care because those women feel safe in that relationship with the known midwife to share, oh, I'm not sure, I don't feel comfortable today, I feel a bit off. Can I come and have a checkup? And that mutual respect and understanding's there in those relationships because they've had time to get to know each other. Yeah,
Yeah, yeah, I think it's such a really good point. Feeling comfort in the person that you are, or that is helping you through this period, and certainly, I know in my wife's case, she was told first time mum, you're just overreacting. You're scared about everything, and actually down the track, it was proven that it was justified. Her concerns were even at the early stage. Um, so yeah, having that continued care, I think, would be critical. As you said, build a
yeah,
rapport. You feel comfortable sharing, um, all the information this person would have, a knowledge of your background and sort of where you're coming from. Um,
yeah,
how do we, in Australia anyway, or certainly in our state in New South Wales, um, are we looking at implementing this into practice? I mean, you've done a lot of research in this area and you're showing the benefits of this.
yeah,
How close are we to getting it actually done?
yeah, yeah. That is another good question. So I think that the most recent data we have on this is that only around 10 to 15% of our population have access to these models. But recently, I've seen particularly like mid North Coast, I worked really closely with the health district and using my PhD to support those models to be implemented and initiated. We've now had all of our maternity sites across mid North Coast have a continuity model or a variation of a continuity of care model because every site works differently. Like mid North Coast is somewhere between rural, you know, small towns to larger regional centres like Port Macquarie and Coffs Harbour. And the way midwives and women interact and need to engage with the service is very different. So they need to work differently, and those models look a little different. Um, but I have seen a large increase in effort to implement these models across Hunter, New England, for example, and Central Coast have a few different models that they've also implemented. So I definitely think there's a big increase in the last like 2 to 3 years towards increasing access to these models. So it'll be good to see what the data around that looks like, I think, for these last few years. But we just haven't got that available yet to know whether it's increased or not. But anecdotally, I have seen a lot of effort being made to increase access to this model of care.
I think this is really important work. I had a sit down with Professor John Aiken, and we discussed the declining global fertility rates. Less people having babies. That there is a population crisis. A larger, older population, and that not being sort of replaced. And so there's a push, and I think governments are starting to realize that we need to have more, you know, people having babies and children. But I guess if you don't have those support networks in place, what you're asking of people to go through, especially women to go through, we need to make sure that we have these supports
Yeah,
systems in place.
yeah,
And I feel that this modeling, this continued care modeling, is a critical um, part of that. One thing that I was shocked when we went through the system, um, and I'd like for you to talk to this, is quotas. And, oh, sorry, not quotas, ratios.
yeah,
I know that, that with nursing anyway, there's a certain number of patients per nurse. And when I was in the hospital, I spoke with some of the midwives, and they said, um, we have a 1 to 6 ratio, one midwife to 6 patients. And I remember thinking to myself, well, how do you work that out if a woman has twins or triplets or, but but they informed me that it was one midwife to 6 women, regardless of how many children that she may have.
Yeah.
And that really blew my mind away because mum obviously needs a lot of care. You know, she's just given birth. She may have had a cesarean or she may have had a natural birth, and you know there could be some complications there, or it could be all smooth sailing, which is what we hope for.
Yeah.
But nevertheless, she still needs support and looking after. And then there's baby as well, and especially if it's a first time mum, as you said, you know, in your experience, you may not be sure of things and you want someone to come in and maybe guide you a little bit and not to rush that process.
Yeah.
Um, so in a model of care, and certainly in a hospital setting, if we have a midwife that's been through the whole 9 months and is at birth, how could that model fit in the birthing process and continued care from there?
Yeah, so I think you're talking about two very different models. They're
Mhm.
structured very differently. So the ratio where there's one midwife to like 6 women and her 6 babies, that is that very standard approach to rostered shift work within a fragmented hospital medical led
Yeah.
type setting. When you work in a midwifery continuity of care model, the midwives aren't rostered shifts. So
Okay.
the one midwife will have what's called a caseload of women, and that can be up to around 36 women, usually a year. So that midwife usually negotiates with that woman what days that suits them both to have antenatal appointments. So the
Okay.
midwife usually tries to structure it so that she's got set days for antenatal appointments that fit around, all the other women she's got in the caseload due that month. And then they're on call for those women and they meet them usually at the hospital when the woman's called them and said, oh, I'd like to have a checkup. I think I'm in labor. They've usually spoken for the few hours prior to it, deciding whether it's time for them to come to the hospital yet or not. And then usually the woman will go home within 4 hours, depending on, if everything goes well and normal. The woman might go home after 4 hours straight away from birthing rather than going to a postnatal ward. So the midwife will then go and see her the next day at home, and then they'll work out when the next appointment might need to be for that woman, depending on her needs. Otherwise, and this might work a little differently across hospitals. The midwife, if the woman needs to stay in hospital for whatever reason, she might have had a postpartum hemorrhage, for example, and needs to stay for monitoring, that primary midwife will likely hand over the woman to the postnatal ward and she'll be part of the postnatal ward core team and their workload. But this midwife will still make sure she comes in and follows up with that woman and checks on her and helps develop the plan going forward. She might be able to go home the next day, depending on whether she's well or not. And then they'll continue their relationship at home. So it is a very different way of working for midwives. And I think that there is a lot of misunderstanding around what that might mean and look like for midwives that have never been exposed to that way of working before,
Hmm.
because a lot of, predominantly majority of women and midwives experience maternity care in a hospital setting where it is that rostered shift work where you'll see midwives working on the postnatal ward, like you explained, looking after 6 different women with, their babies as well. The ratios have been looked at only very recently. Um, that was reduced. I can't remember exactly what it was reduced to, but that does definitely apply to, more likely the larger tertiary centres where they have more women and they have more staff. For someone like me, and I can only speak for experience of working, in Port Macquarie, which is a smaller regional town, we don't have the number of midwives to staff a postnatal ward and have, 3 or 4 women to the one midwife. That's just it's not possible. So you
Mm.
can't We just haven't got the staff to support that kind of ratio. We would love that, and it would definitely improve, I think, work satisfaction and reduce work burnout, all those things that we've been trying to, advocate for. But the reality is we just can't, we can't do that all the time. And on a weekend at, night duty, there's two staff on a ward, and you could have up to 18 women on the ward that you're looking after with just two midwives. It's a negotiation that happens nearly every weekend, every night duty, and you can't control what comes in to the door in, maternity. You could have 5 women come into birthing all at once, and there's only 2 staff in birthing, for example. So you're always trying to manage what's going on, prioritize who you can. And it's not always like that. There's very quiet periods, there's periods where it's really easy to manage the workload, and then there's periods where you're very overwhelmed and there's not enough staff and there's too many women, and it's just something you can't really control either. And the staff work so hard.
Look, without a shadow of a doubt, the midwives that we came across at Gosford, um, can't speak highly of them. Or enough, can't speak highly of them enough. They were fantastic. They were supportive. Um, Little things as well that they would do for my wife that made her um, feel special and appreciated in that time. I know one of her midwives, I've forgotten her name, but she braided her hair, just before going in. Very, very, like just a very small touch, but
Yeah,
it meant the world to her. Um, yes, there might be quiet periods, as you said, but I'm thinking about, a place like Port Macquarie. If you do have a night, 20 women coming in and two midwives. Yeah, I'm not surprised that there is burnout and things in that area. Um, at least if we look at implementing this continued care model and we see some of the results coming in, and as you said, there's some anecdotal evidence now that's showing that it is beneficial. And hopefully, once the numbers come in, it will solidify that point. How would we go about implementing this and making this care available to, say, communities that, maybe, again, regional or from a lower socioeconomic, demographic? How
yeah,
can we kind of, would we approach or would you have those in those communities first, or how would that look like?
yeah. This is really at, that was the core question for my PhD. I just wanted to go back. You mentioned that there's anecdotal evidence for this. The anecdotal evidence I was talking about was more around access to these
Oh,
models. We
apologize.
just
Yeah,
don't
sorry.
have
Yep.
the data around, that's current,
Mm.
exactly how many women can access it at this very moment. But there is very strong Cochrane reviews showing
Oh, okay.
that
I
the
apologize.
outcomes,
Yeah.
yeah, no,
Yeah.
that's okay, which is why I'm so passionate about it. And this was one of the major findings in my PhD,
Mm.
is that not enough people know just how just the crucial outcomes that this model of care can improve, and compared to what we are currently offering. So I'm really passionate about that. So I just wanted to make that really clear, that there has been a long history of very robust evidence behind these models and why we should be implementing them. Um, then going on from that, I couldn't understand why we don't have access and why it's not standardized as the norm for everyone to access this care. That's why I pursued a PhD around it. My PhD did focus on regional areas in Australia and what we can do, what are the barriers, and what are the facilitators for implementing these models. The biggest barrier to implementing these models was, it really shocked me, it was actually the midwifery workforce. And it came back down to the way we work in fragmented medical led settings really inhibits our practice as midwives and stops us from working our full scope of practice. So, a lot of the participants I interviewed spoke about for example, in rural regional areas, there's a lot of GP obstetricians. So the women often see the GP obstetrician as their primary care provider throughout pregnancy, rather than seeing midwives in an antenatal clinic if they're low risk. So the midwives miss, frequently practicing those antenatal care skills. They'll often work in a postnatal ward. A lot of the midwives I was interviewing talked about being feeling really familiar and comfortable working in a postnatal ward because the women, they see them there regularly, whereas an obstetrician, GP obstetrician, kind of doesn't need to be there all the time for that area of care unless something happens and they need to escalate to them. And then in the birth setting, a lot of the midwives talked about the obstetrician or the GP obstetrician wanting to do like a lot of them. Sounds really crazy because vaginal examination is something that um, it can be controversial. Um, and we use this skill to assess how quickly a woman's progressing. So it forms, it informs our plan of care, what we're doing. And a lot of the obstetricians or GP obstetricians mandated that they were the ones that needed to do that skill because at the end of it, they were the ones that were going to be making a decision if they needed to, you know, escalate care for whatever reason or change the pathway that the woman was on. So there was a lot of skills that midwives identified that they were not getting practice in regularly, which undermined their confidence to feel like they could step into a model where they were then going to be the lead care provider. The other part of it was also that at the time of my PhD interviews, we had a very an aging workforce. So a lot of the midwives felt like they were going to probably be retiring within the next 5 years and didn't feel like they wanted to be upskilling for something that they weren't going to be wanting to work in because they were nearing retirement. So there was a lot of conversations around that as being a big barrier to implementing these models. It wasn't that a lot of the midwives knew that it was beneficial and important and we should be increasing access to these models, but there is a lot of barriers for them as a workforce to feel confident that they can see themselves working in this model. Um, and a lot of them have never seen what it looks like to work in this or even had the opportunity to talk to a colleague who's worked in a continuity model before either. So there's not those, tea room conversations around, I've had all these lovely women who are not due for a month. So my workload's been really good. I've been able to go see my kids at their school assembly, things like that,
Mm.
for those midwives that work in continuity of care where they can be a bit flexible around their workload. Um, and then the midwives that are core midwives that have not had that opportunity, there's a lot of misinformation that if you go and work in a continuity of care model, you will be on call 24/7 for your women because they just haven't had that opportunity to learn about it. They haven't had those role model midwives to go to and listen to and see how these models work and operationalize. So there is a lot of fear around implementing a new model of care and what that might look like for midwives who, I guess, haven't had exposure to it before.
And with the OG midwives, the ones that have maybe retired, uh, are you finding that the newer group that's coming through, are they more open to these different models and implementing them?
Yeah, definitely. My colleague Professor Alison Cummins and I actually have done a bit of research around new graduate midwives and transitioning them straight into these models. Alison's PhD was actually on that topic, and she helped implement one of the first midwifery continuity of care models in Sydney. And her experience was that the new graduates were the most keen, the most passionate, and had the most recency of experience working across that whole continuum of pregnancy, birth, postnatal period. And we're really passionate about it because they just graduated and they had just, finished their continuity of care in their undergrad. So that is her passion topic. And I definitely do see that midwives who are graduating now are really keen to, pursue that as a career option. And also seeing off the back of that, health services looking at ways where they can support new graduates into these models as well.
So, at least the continuity of care model throughout pregnancy, which I think is fantastic, just from a civilian's perspective, having the same midwife go through, say for my wife, I think would have been amazing. Um, if we get to a point where this becomes a more commonly practiced throughout the country, which would be fantastic. How would this model look for after birth? So let's say birthing was, for all intents and purposes, relatively smooth sailing.
Yep.
Um, what would that look like now we have a baby?
Yeah.
What goes on now?
So, all well, usually most women will stay in birthing for around 4 hours, and their primary midwife, usually depending on how long, I guess, labor and birth were, and the midwife was there, they have a sort of protected period of, a 12-hour time frame. So they shouldn't really be going over that if, labor goes on for more than 12 hours. They will hand over to their buddy. But all well, labor progressed within the 12 hours and they've been there for the 4 hours. Usually that midwife will make sure they're okay, ready to go home. And then before they leave the hospital, they'll plan to meet them, the next day, usually. Um, and then she'll come and visit them at home. So, having seen a midwife throughout your whole pregnancy, you have that time and opportunity to talk about what that might look like for each individual family, and woman and her partner, or birthing person and their partner, because they'll all have different needs and concerns or things that they might need to a little bit of extra support around. So that sort of comes up in those antenatal, naturally they'll start talking about that usually towards the end of pregnancy, what the postnatal period might look like for them, what's important to them. But it is an interesting question. We did an evaluation on some of the models we implemented in the Mid North Coast, and the feedback from the women around postnatal period was so lovely. Women love their midwives, and it is such a special time for families, but also it's such a privilege to be part of that. And I always get really, it's so heartwarming when women tell you just how special midwives are to them. And they wanted midwives to look after them in the postnatal period for up to 12 weeks. That's what their feedback was. Our role finishes at 6 weeks postpartum. That's our scope of practice. We then hand over care to usually a woman's GP or the community nurses, and then they'll look after the woman in the community. There's different options. Um, but just to hear, that's not the first project I've done where we've collected women's feedback on continuity of care, where women have asked for extended periods of postnatal care with their midwife. And it's just so nice to hear just how special that is for them.
Well, you've only got yourselves to blame for doing such a good
Yeah.
job. So, so yeah, actually, we went to a a cafeteria, Warnie's. It's on the Central Coast. If you are on the coast, Warnie's is a great cafe to go to. Food and coffee is fantastic there. Um, left Bub with Grandma, and we went on a little date together.
Aw.
And my wife just sort of spruiked up suddenly and just runs outside, and the midwife that braided her hair was there with her
Aw.
mother.
Yeah.
And I could see she went up to her and was talking to her and came back. And when she came back and spoke with me, I said, "Did she remember you?" She goes, "No, she didn't, because obviously it's been a little bit of time had passed, and there's so many women that have gone through, and but she was just so chuffed, to see her. She was so happy, and just wanted to go and say thank you. That I could see that the midwife was also happy.
Yeah.
So it doesn't surprise me that these women want that, and you build a relationship with someone for 9 months. Uh, it's a big 9 months in your life, major
Yeah.
event, and so
Yeah.
I can see. So I guess how does relationships look like? How do you, as a midwife, go about in a continued care model, building these relationship with your patients and getting them to feel comfortable and assuring them through this process?
Yeah, that I think that looks different for every woman, birthing person, family. Um, I haven't had the privilege of actually working in an MGP or a continuity model myself because I've, worked in academia. And when I do work clinically, it's a casual shift. So it is, in that fragmented hospital setting. Not that I wouldn't love to, I just haven't worked out how to juggle the academic,
Yes.
clinical, still working on that. It's in the pipeline, but eventually would love to be able to do that. But I still think it does come down to just asking the women and listening to them around what they need and doing your best to prioritize that and not forget it and not let it get lost in clinical care. Um, it's really difficult when you meet a woman in birthing, for example, and she is already in established labor, to build a rapport with her, to be able to ask her questions. But for me, one of the first things I always ask women in that is what are your priorities and what do you need me to do for you to meet, you know, what it is you're looking for in this space? Because I know what I need to do clinically to support her and make sure I'm creating a safe environment for her. But the biggest thing for women is, I think, being listened to and made feel like you are doing your very best to support their needs in that time. And that does look very different for each person and woman, family, husband, partner, children.
Yeah.
Yeah, yeah.
Yeah. And Elysse, your research, what's on the cards? What are you guys looking at and into now moving forward?
Yeah. Um, so off the back of my PhD and the projects I've done with the Mid North Coast around implementing these models, a continued repeated theme around this is just how important it is to engage with our consumer maternity consumers. Um, Unfortunately, in this, predominantly fragmented care model, women often feel like they're not heard, they're undervalued, they're not listened to, and they really don't understand the power that they hold in being able to change the way we deliver maternity services. And there's not a very good pathway for them to identify either to be able to contribute to maternity service changes and improvements. And that's something I'm really passionate about and looking at pursuing now. So I think a lot of working in a hospital setting, we are really evidence-based. We promote evidence-based care. We like to try and offer care that is, based on the most current, strongest evidence. But when you look at that, overall, largely the evidence base is around preventing or treating and managing um, maternity complications. And I think that has really influenced and plays out in everyday practice now, where we're seeing a really strong fear of, trying to manage a pregnancy, labor, birth, and avoiding risk. And unfortunately, that means that a lot of women who are well, healthy women have ended up having intervention because we're trying to prevent adverse outcomes for women that might never have experienced it. So, research is a lot that underpins our practice is really around trying to treat and manage that. Whereas I think we need to come back to, what do women want? They need to have a stronger voice, and there needs to be more evidence, implemented around what are their needs, what are their priorities. And I think that'll help contribute to reducing what we've seen recently in the media around, the birth trauma inquiry in New South Wales. A lot of what that shows was that women felt like they weren't being listened to. They weren't central decision makers in their own care. And I just think if we had more evidence to be able to underpin our practice to support them to be part of that process and listen to, then I think it would really start to change the way maternity care is provided. And women, they want access to continuity of care. And I think that's probably at the moment the gold standard of practice in being able to, provide that kind of care.
I would, even though I'm the other half of this equation, I can feel confident to speak on her behalf. I think my wife would completely agree with that. And if she had the choice of having continuity of care, she would jump on that. And I hope sincerely that your research is taken and is built on, and that the system can listen to this and implement it, because it's what people want, and the evidence that you guys are showing of all the benefits, that's not a insignificant finding. So,
Yeah.
um, Elysse, thank you so much for spending the time with me. I've learned a lot from this, and I hope, if it hasn't been too traumatic for you, that I could have you on again in the future and talk about some other topics that are related to midwifery.
Yep,
Um,
absolutely. I have some colleagues too, I think that would be great to have a chat with.
no, that I'm more than happy to do that. Again, as I said, this is very much from a selfish perspective. I learn a lot speaking from different experts, and hopefully people will watch this and learn as well, and see all the great things that the academics are doing, and we're doing and are doing this for the benefit of people as well. So
Yeah.
um, yeah, thank you so much for that, and I hope to talk to you soon.
Yeah, thanks, Mo. It was great. A nice way to spend Friday morning at work anyway. So thanks for the invite.
Absolute pleasure. Okay, Elysse, I'll talk to you soon.
Yeah,
See
cheers.
you. Bye.